Hello, everyone, and best wishes to everyone all over the world from Lucerne, Switzerland. We have today a fantastic opportunity to discuss about a very important topic. The topic is in-stent restenosis, but I'm sure that we will also be speaking about stent thrombosis. As you know, in-stent restenosis has become more rare in the recent years, but it has not disappeared completely. And stent thrombosis is also rare, but it has not disappeared completely, and it carries a lot of catastrophic potential for the patient. We will speak with different experts from all over the globe, and I'm very excited that we have a very nice panel. And we will have the presentations from our speakers with their cases, and then after every case we will be discussing the case and try to really find the best solution for these patients and see if we would have done maybe something differently, or if we think that maybe in the future another thing should be added to this case. Let me introduce the speakers which are today with us. We will start with Professor Géraud Souteyrand. I hope I spelled it right. And Professor Souteyrand works in France. And he will speak about OPN balloon and how really it is useful to use the balloon in daily practice. Then we have my friend, Professor Legutko from Krakow, and he will speak about something very interesting about combination of IVL, so lithotripsy, and OPN in recurrent in-stent restenosis. I'm very excited to hear that talk. Then we have my other virtual friend. I've never met him before live, I think, but I know him from LinkedIn and from the social media. And this is Dr. Krzystof Pujdak, and he will speak about PCI in calcified left main stem. The devil is in the detail. Also very excited to hear that. And then we have the honor to have also Professor Wong with us. He is connecting from Singapore, and he will speak about a hard case to crack. And also this is going to be interesting to hear the case of Professor Wong. So without losing more time, please first Professor Souteyrand from France to share his case with us, and then after the case we can discuss it. You can ask questions, and we will try to implement and answer all the questions you have. Thank you very much.
Thank you very much, dear colleagues, dear chairman. It's a pleasure for me to show you this case, and I think that it's a very interesting case and that we could discuss after the presentation. So how to use OPN NC balloon in our practice. So it's a woman of 64 years old, only coronary risk factor is overweight, and she suffered in 2014 of an acute coronary syndrome with ST elevation in inferior leads, and she benefited of a stent on the right coronary artery 2 hours after beginning of the pain. 2 weeks later, she benefited of another angioplasty on LED and marginal branch with a good outcome. We didn't have the angiogram at this time. She came in our institution 4 years later with a chest pain at rest for 30 minutes on EKG there was only the ejection fraction was perfect without any mitral aortic valve disease. I can show you here the angiogram. I think that you see the right coronary artery, which is very calcified, but there is no stent restenosis on the right coronary artery. There is only a tight stenosis in the distal part of the right coronary artery, which is very small. I can show you on this slide the left coronary artery, and you can see here that the main problem is on the LED. You can see that LED is very calcified, and there is two very tight stenosis, which seems to be in the stent. We didn't have the previous angiogram, but we thought that it was too tight stenosis in the LED. So we could discuss after the case what you do at this time. I think that the angiography is not enough to explore this type of stenosis. That's why we decided to perform OCT. You know that OCT is well recommended in stent failure, and I will show you the pullback of the LED. You can see here that the stent in the distal part of the LED, which is coming now, is well opposed, but there is a very tight stent stenosis in the distal part of the LED and another stent stenosis. And what is very interesting in this case is that we have two different mechanisms of stent stenosis. I will show you in these two next slides. It's on the video. On the right, you have the stent stenosis of the distal part of the LED, and there is an homogeneous neointimal stenosis with a good opening of the stent. But when we look on the stent just before, you can see here that the stent is very underexpanded on the calcified part of the LED. And we didn't see it on the angiogram. And when we look after the angiogram, which was performed 4 years later, it was not seen on the angiogram. So when we do measurements on OLDI, it's very impressive because, like you can see here, the stent it was a 3 millimeter stent, and the diameter of the stent on the under expansion is only 1.4 to 1.8 millimeter, and the area of the stent is only 2.5 millimeter square. We know that when you have area stent less than 4.5 millimeter square, it's a big risk of stenosis in the follow-up. And when we look on the proximal part of the stent, you have a stent mean diameter of 3 millimeter with a stent area of 7.2 millimeter square. So at this time, it was logical to treat this lesion with angioplasty. I can show you the 3D reconstruction of the stent, and it's very impressive to see the under-expansion of the middle part of the stent, like you can see here. So we were on a radial approach with a 6 French catheter. We use our usual wire, which is a cyan blue wire, and we try with a non-compliant balloon of 3.5 millimeter of diameter, but with a dilatation at 22 atmosphere. You can see on the screen there is still a notch on the balloon, and we didn't can open the stent adequately. We tried with another balloon of 3.5 to 12 millimeters, 3.5 to 15. I think that we tried with 10 attempts to do the angioplasty, but there was still a notch on the balloon. So we tried to do with a smaller balloon, because with a smaller balloon we could have a stronger stronger with the balloon, but with a 3 diameter balloon with a length of 10, we have always a slip of the balloon in the downstream to the lesion in the distal part of the LED. That's why we decided to try with 2 wires, like we can see on this slide, with an extra super wire. We tried to do the angioplasty, but it was the same problem with the slipping of the balloon. At this time, we were disappointed, and we decided to try with an OPN NC balloon. At this time, you know that the OPN has a big strength, but the principal limit of the OPN balloon is that the crossing profile is less than the other balloon. And like you can see here, we didn't allow us to cross the lesion with the OPN because of the crossing profile. That's why we decided to try with the Godzilla, and with the Godzilla we can go with the open balloon in the stent. And at this time, when the open balloon was open at 32 atmosphere, we achieved to open the stent with a good result. After the open NC balloon, it was very easy to go with a DUS of 3.5 to 33 millimeter with an excellent angiographic result, as you can see on the screen with the movie. On the angiographic, there was no dissection in the distal part of the LED, and we performed just after a control on OFDI to be sure that there is no dissection, that there is a good apposition of the stent, and that there was no underexpansion. On the pullback of OFDI, we had a very good result with a minimum stent area more than 6 millimeters square, and there is only a middle malapposition in the proximal part due to the several atoms of angioplasty before the angioplasty of the stent. And what is very interesting is the differences between the angioplasty before the open and after. You can see here at the left the underexpansion of the stent, and after the OPN we have a very good result on the OFDI pullback. And when we look just on the portion of the stent underexpansion, at the left you have the stent with a diameter of 1.4 millimeter in diameter, and just after the OPN you have the good opening of the stent. And I think that without any OPN we didn't achieve this result. It's a very good tool in this problematic stent prostenosis. In conclusion, I think that in all these cases with stent prostenosis, angiographic is very limited to understand the mechanism of the prostenosis stent. And I think that we have to perform OCT, which could allow us to adapt the therapeutic strategy. And in my opinion, OPN balloon is an essential tool now to treat this underexpansion when you have a lot of calcification, because the classical balloon are not able to do a good work in a lot of cases. And if you implant a stent with an underexpansion, you will add a problem with the preliminary problem, and in the follow-up you don't have any good result. Thank you very much.
Thank you very much for this very nice and impressive case. From my side, I have just two questions or comments. My first question is, why did it take you so long? Because apparently you had the OPN on the shelf. So why did you use 5, 6 other balloons before you decided to use the OPN?
It's a very good question. I think that it was in 2018, and I had no lot of experience at this time of OPN, and now I use OPN in a first option or second option. When I see that the balloon doesn't achieve to open the stand, I go with OPN. But I show you only a few parts of the procedure, but it was very difficult procedure because I had a lot of trouble to go inside the lesion with the OPN too. Sometimes it's very difficult to cross the lesion because the crossing profile is not so good. So it could be an issue to treat this patient. So sometimes to do a predilatation with a classical balloon could help to cross the lesion with the OPN.
So maybe if I just add one short comment here. So usually I would predilate with a normal non-compliant balloon of a lower diameter.
Yes.
And then, of course, I think the important thing is the wire. You use the cyan blue.
Yes.
And the cyan blue is a good wire. I use it every day, but it's not a high supportive wire. And I think if crossing is a problem, then maybe also for the people who now listen, the OPN has a higher profile, and we have to adapt with our material to that higher profile. And for that, I would use an extra support wire. In our case, we use, if you say OPN, you say Grand Slam. So usually that's always combined in my lab, and then we use both together. And then usually crossability becomes much of a problem, or much less of a problem as it is with the cyan blue. Or sometimes I see people with a BMW and OPN. That's then definitely when I start to have angina myself. Now, I have one other question before I ask my other colleagues, maybe if they have some comments. The second is, why did you use a 3.5 balloon? You used a 3.5 OPN. Why did you go to 3.5? Because let me just finish. Because your minimal diameter in the stent was 1.4 by 1.8. So apparently your calcium ring was much smaller than 3.5. So why did you upgrade to 3.5?
Because when we do the measurement of the reference stent area, it was 3.3 millimeter on the just upstream to the lesion. So we try to have the best result and the best opening of the stent at this portion of the stent. That's why we decided we could try with a 3 millimeter diameter, I think so. But sometimes you have a notch with the open balloon, and that's why in this case I choose 3.5.
Let's maybe open this question, because I think sizing, because we have to be, when we use the OPN, we have to make the procedure safer and not unsafer. So let's ask maybe Professor Legutko, would you have chosen a 3.0 or would you have gone also for a 3.5? Let's do a survey with our speakers, what they would have used in this case.
Personally, I would rather go for stepwise approach. So it means 3.0 could be a good option. Then you can always check with OCT what happens and maybe go to 3.5. If it is really intravascular imaging guided procedure. And I have one comment to this case and one question to the speaker. Comment is that thank you for showing us how important is intravascular imaging when you approach the patient with instant failure. Because in this one case, you have shown that two very similarly looking stenosis on angiography, they were caused by completely different pathology. One was neointimal proliferation, and one was stent under expansion, and both are usually treated in different ways. So I believe that it was beautiful demonstration, and thank you for that. And the question is, have you used drug-coated balloon, especially for this distal lesion, which was just the neointimal proliferation, or just OPN balloon to expand the stent and to?
So I think it's a very good comment because when we don't use OCT, in this case, I think that you will go with a classical balloon and you don't have any good results. In this case, it's a little difficult because we have two different mechanisms of stent restenosis. I think if we have only the classical neoantimal hyperplasia, like in the distal part of the LED, I treat this patient with only active balloon. But in this case, when we do the stent, like you can see, we have choose a long stent of 33 millimeter, and we covered all the two both lesions.
Krzystof, tell us how would you have treated this case similarly? Meaning, tell us about the diameter and what pressure would you have gone? Unmute yourself, please. We can't hear you, Krzystof. Unmute yourself.
The mic, yes.
Can you unmute yourself, Krzystof?
Yeah, right now it should be fine, thanks. I didn't understand the question because my mic was gone for a moment.
So the question is, would you have also used a 3.5 balloon or rather 3.0, and what's the pressure you would have gone up in this case?
Well, I will show some similar case later on, and I think I would have a look on the reference diameter proximal to the lesion, and then according to this measurement I would choose this stent. So in this case I would probably do the same like it has been shown. So I would go for 3.0, look what it will look like, and then upgrade to upsize to 3.5 and to achieve the reference diameter which was measured proximally to the lesion.
Okay. Now, Professor Wong,
yes.
Tell us how would you treat this case in Singapore?
Yes, I think the reason why the stent wasn't fully expanded about 4 years ago is probably due to severe calcification. So in this case, I would use a 3.0 to expand the lesion. So I think after it expanded with the 3.0, it cracked the calcium. I don't think you need to use another OPN to dilate it. I think usually a normal NC balloon will probably be able to crack the lesion if you want to expand the stent further. Yeah, so I would use just one OPN, and then if it's fully dilated, I just use a normal NC balloon to dilate the lesion to be on the safe side, not to rupture the artery.
Yeah, very good comment. And I think maybe one final comment before we go on. What do you think? In my opinion, with the OPN, we do two things when we treat an instant restenosis. On the one side, we expand the stent. But on the other side, I think we compress the tissue like with no other balloon in a similar fashion. Because especially if you want to put another stent there, you need to really make room for this stent. And what we observe sometimes, you see these patients treated, they might have expanded the stent, but they did not compress the tissue. So when they put another stent and they don't do an aggressive pulsation, you will have these gaps between the stent layers. And at the end, you have this onion skin phenomenon. So I think with the OPN, the compression of the tissue is as much as important as the expansion of the old stent. Professor Souteyrand, you had also another comment. Unmute yourself, please.
Sorry. No, I will just add a comment. It's when we look on the result of the stent after the 3.5 millimeter of OPN and the stent, the stent was not really circular. I don't know if you have seen on the pullback of OBI, but the calcification seems to be difficult to open always, and we have only stent area of 5 millimeters square. So to to have in mind that it was a very difficult angioplasty with a lot of calcification, and I think that the 3 mm 3.5 it's not a really big matter because we don't have a perfect result at the end of the procedure due to the big of calcification, the edge calcification.
Thank you very much. Very important comments. We have some questions from the audience. So one asks regarding the sticking of the balloon. He said, we have great experience with the OPN balloon. However, the balloon can stick to the wire. Maybe Professor Legutko can answer briefly this question.
I have no such an experience that I have a problem with this. Maybe you can comment. You have much more experience with OPN balloons.
Well, it has something to do with the use of cyan blue usually, because of the architecture of the cyan blue. So usually if you go to very high pressure, and especially if you pull your balloon quickly back, because you have gone to such a high pressure, this is not unique with the OPN, it's also with other balloons, sometimes it sticks on the wire and then you lose the access to the wire, you pull out the wire. So the way to do it is either use a Grand Slam, which is not a coated wire, or you should do it just very gently and then give it a lot of time so the inner lumen of the wire lumen expands, and then you can remove your balloon safely without pulling out the wire. And maybe one, there's a lot of questions already. One from Singapore actually asks, explain your rationale of using two short 3-0 non-compliant balloons together and then risks of perforation. So he means maybe put two balloons parallel, I don't know. Yeah, that's, huh? Yeah. So what I have done is use once I could not crack the lesion with a 4.0 OPN balloon, and I used 2.0 OPN balloons in the same vessel. And I went up to 35 atmospheres, and this cracked the vessel and did not perforate. But I was very anxious actually when I deflated that now we will have a catastrophe. So for the sake of time, let's move on. Let's ask now Professor Legutko to demonstrate how he combined intravascular lithotripsy and OPNNC in a patient with recurrent instant restenosis.
First of all, thank you very much, Florim, for inviting me to this excellent session, which is, I believe, very educative. And we are talking about the OPN-NC balloon, which I have an experience for more than 10 years, not as big one as Florim, but I did a lot of cases, and this is the device that I like, and this is the device that I promote in Poland for every CAD lab to have in shelf, because sometimes it can save the procedure. However, for today I have a little bit provocative cases because I would love to show you that sometimes even OPN balloon can be not enough to escape from the trouble during percutaneous intervention. Of course, successful coronary stent implantation is challenging in severe calcifications, and severe calcifications, in fact, are usually associated with stent failures, either stent restenosis or stent thrombosis. And this is why we believe now that the proper lesion preparation is extremely important, that this is not only for which is no more on the market, so bioresorbable scaffold, but for any kind of stent implantation, it is very important to appropriately prepare the lesion, especially calcified lesions. And here, very high pressure OPN balloon is one of the devices which is more commonly used in my CAD lab. Of course, for some cases, we still need rotational atherectomy, and this is like 100 cases a year in my center, where we do 2,400 PCIs each year. And there is a new, very promising method, very expensive now. However, I believe that there is a future for intravascular lithotripsy also. My case, which is the topic of the presentation, is 67 years old male with typical risk factors, and the past medical history included anterior STEMI, which occurred in 2005 and was treated with primary PCI of LAD with bare metal stent implantation. This patient came back to the cath lab 4 years later, and the in-stent restenosis was recognized, and in 2009 he was treated with additional stent implantation. It was first generation sirolimus-eluting stent. And then the patient was asymptomatic for the next 10 years, and the recurrence of angina occurred in 2019. Patient came back, and we did angiography, and we discovered this is the LAD, which was previously treated with 2 stents. You can probably clearly see here a stent which was implanted. However, still we can also see something which looks like calcified neointima. There is also the calcium also out of the stent. The lesion looked borderline on angiography, however, is a long lesion, and we did physiology assessment also, and you can see RFR is 0.69, so we have confirmation for ischemia in this patient. When you look on the stent enhancement, then you can clearly see that during those 2 previous procedures, the stent has never been properly expanded. There is some calcium behind the stent. However, there is also a suspicion of calcium within the stent, which could be the so-called calcified neoatherosclerosis. This is intravascular ultrasound, which confirms diffuse disease in LAD. There is also some disease at the edges and some calcified lesions proximally and distally. And this is at the site of maximum of minimum lumen cross-sectional area. You can see 360 degrees of calcium, which is just, as I said, calcified neoatherosclerosis within the 2 layers of stents. So this seems to me like one of the most difficult lesions to be treated by percutaneous intervention. We have 2 layers of previously implanted stents, and we have also stent under expansion due to peristent calcifications, and at the same time we have calcified in-stent neoatherosclerosis. Taking all into account, and also the fact that in my center we have the program for minimally invasive coronary artery bypass grafting, Lima to LAD, our surgeons, they have good results. We offered this strategy to the patient. However, he absolutely refused surgery and asked us to do the intervention. So I started this with what is promoted and what is effective in majority of patients with in-stent restenosis, to be honest. So I used OPN balloon. However, multiple dilatations were ineffective to open the balloon within this calcified neoatherosclerosis. This is the result, which is suboptimal, and still I believe it is not a good time to implant additional stent or even use drug-coated balloon. This is why I decided to use the new technology. As I said, patient disagreed for surgery, so I used intravascular lithotripsy, the different approach, because in this strategy we don't use high pressure balloon inflation. We use just like 4 to 6 atmospheres maximum. However, we use the sonic pressure, which cracks the calcium. And what is important, especially for such patient, that it is effective for both intimal and medial calcium. So using, for instance, in this case, rotational atherectomy, I can cut the calcium which is within the stent. However, there is no impact on the stent, on the calcium which is out of the stent, and the same for excimer laser. So I thought this can be the good option, and this is the IVL balloon catheter, multiple inflations. You can use 8 cycles, and each cycle gives you 10 pulses of ultrasound energy. So this is what I used, 80 pulses, and afterwards still you need to do proper post-dilatation. However, now you can see that OPN balloon fully opened even at 32 atmospheres. This is the result by angio, which is now much better than before. because of the disease which was diffuse by intravascular ultrasound, not only instant restenosis, but also diffuse disease proximal and distal to the stent. I implanted i.e. decided to use additional drug-eluting stent, and this is the final result of the procedure in patients with really resistant lesion for standard balloon predilatation. And now you can also see on the stent boost very well opening of the stent without stent under expansion. To show you also how effective intravascular lithotripsy can be for under expanded stent due to the severe calcium, the next case was really amazing, and we as the operator were really amazed. And this is also the case that I would love to show Florim, because it shows us that something can happen which he promised me never happen with OPN balloon. So this is the case with non-ST elevation myocardial infarction admitted to our hospital, and the culprit lesion was clearly in the mid part of the calcified right coronary artery. However, there was also diffuse disease in the distal part of the vessel. This is aerial projection. Left coronary system was also involved. However, the decision of the operator was to treat the culprit vessel first with percutaneous intervention. And for proximal vessel, he used standard approach with OPN balloon predilatation followed by drug-eluting stent implantation, and this was very good result and very good opening of the balloons. And the operator was so happy, and he thought this calcification is good for balloon predilatation, balloon dilatations, that he decided to implant another stent without proper preparation of the lesion. And this is the result. It doesn't look so bad. However, we clearly see that the balloon is not fully open in the distal part. However, the result was even worse, and this is the angiography, which was done immediately after stent implantation, and you can see severe stent under expansion in the distal part. Decision was simple, our straightforward approach, so to use OPN balloon, and this is the OPN balloon at 40 atmospheres, which is still not opened, and in a second this balloon ruptured. So something happened which was strange for me, and I would be happy to hear the comment from Florim, because he told me when visited my CAD lab that it never happened. It happened in this case. So we decided to switch the strategy. I joined my colleague, and this was fifth or fourth or sixth IVL case in the CAD lab. So we again introduced intravascular lithotripsy catheter. We did multiple pulses, and this is the result immediately after. We were afraid about stent rupture caused by the calcium or even by lithotripsy. This was never checked, and the lithotripsy was never appropriately assessed to treat under expanded stents. So this is why we decided to use additional stent, and this is the final result of the procedure. As I said, there is not too much of good scientific data supporting the use of intravascular lithotripsy. We are in the beginning of the road. However, there is first registry which was published 1 year ago with quite good results, and by OCT it was confirmed that the way of the mechanism of action of lithotripsy is just to create intraplaque calcium fracture, which was confirmed in 80% of cases as a very safe and effective method, and we'll see what will happen in the future. Nowadays, of course, our current strategy is mostly to use non-compliant balloons, and OPN balloon is probably the most effective approach. However, still for some cases of undilatable lesions, even with OPN balloon, or when we have a problem to cross the lesion with quite bulky balloon like OPN or lithotripsy balloon, we still need to use atherectomy to prepare the lesion. However, lithotripsy is also here to stay, and I believe that it needs further evaluation and further assessment in the CAD lab in our everyday practice. Thank you very much. This is what I prepared for today, and I'm open for questions.
Thank you very much. Very good and provocative cases. Maybe for the first case, I think actually both cases, it's nicely done. And before I answer the question you asked, I think we should not be really like Talibans and try to exclude things. And this is not about religion. I think we should combine the best tools we have for the cath lab, for the patient. And the reason I believe OPN is such a good tool, it's because it's available everywhere. It's rather not expensive, and compared now in our lab compared to IVL. So IVL here is in Switzerland is quite expensive, even for a Swiss cath lab. So I have to be careful how many of those balloons to use, whereas OPN is less expensive. So that's why I think we have to choose our tools for our patients. But I believe that a large portion of the lesions need combined approach. And I believe that the OPN balloon is always in the center of this combined approach, because you will use the OPN even with lithotripsy, and maybe with Professor Legutko, we have to pull the cases, because we have now also some cases with IVL and OPN, and maybe we should just put them together and have a nice review. Now, regarding your second question about the rupture of the OPN, there's basically two mechanisms why the OPN can rupture. One mechanism, and I think in this case probably that's what happened, is that you damaged if the stent basically didn't open up at all. So when you put the OPN down, you usually damage the OPN while introducing it in through the stent, which is not opened, and then you inflate it, and then it can rupture, or it has a pinhole, and then you cannot build up pressure. And the second, it happens. I never said it never happens. I said it happens very rarely, but it can happen rarely that the OPN balloon explodes. However, and this is very important in my opinion, if the OPN balloon explodes, it's a controlled explosion, because you have this double layer architecture. If you inflate your Trek NC balloon at 35 atmospheres, at 3.5, and it explodes, the whole energy goes into the vessel wall, and then you will need two covered stents to cover the mess. So it can happen. It's very rare, but even if it happens, it's not a catastrophe, and I think we can combine two technologies. Are you happy with my answer, Jacek?
I love your comments, and I believe, it was a little bit risky for me to present the case and the balloon ruptured on the session which is organized by SIS Medical. But this is because we would love to be fair and to show all problems that we experience in the CAD lab. And as I said, we did like 10 cases of intravascular lithotripsy for the last year, because it's expensive. Maybe if it is cheaper, we will use more. We have used like 100 rotablations, and we have used hundreds of OPN balloons. Because it's very effective in majority of patients, is just enough. However, what you said is very important, that we should not be really aggressive. When we start with one technology, we need to finish with this one technology, because in some patients we need to use multiple technologies. And even if I do my rotablation case, I just try to use only small bears to cut the calcium, and then use non-compliant, and if it is very calcified lesion, OPN balloon to prepare the lesion, because rotablation itself is just not enough to appropriately prepare the lesion. So my cases, I just wanted to show the combined approach. So sometimes it's even, and I did such case at the workshop in Warsaw that you probably know, organized by Professor Witkowski and Gil last year, that we did with Tomasz Pawłowski. Very simple. It looked like quite simple LAD diagonal case, but at the end we had to use rotablation to be able to deliver OPN balloon, which was not fully effective. We needed to use again lithotripsy, then decay crash, and finished with OPN balloon post dilatations to appropriately treat the lesion. It was live case demonstration. It was quite long, but I needed to finish it during the break, and for 30 minutes break, the room was full of people. So this is why I decided, to take a risk to present during the session not only OPN but also something else.
But let me maybe before we involve Krzystof and the other colleagues, I think I think for the company, for SIS, it's actually good news, because if people combine these different technologies, then they will increasingly do more and more difficult cases. And I think then they will use the OPN balloons, because the OPN will always be in the center of this all technologies, because you cannot finish the case with just rotablation. You will need a strong balloon to have a good result. So I think at the end for SIS, it's good if we start to combine our methods. And I have, for example, 4 cases where I used rotablation, cutting, cracking with the OPN, and lithotripsy in the same case. I was heavily criticized because I put one case on LinkedIn, and one said, only in Switzerland you can do this, but it was needed. It was in the middle of the night. Nothing was helping. I had an impeller in place, and I said, it has costed now already 30,000 euros. Let's add another 2,000 and get a great result, and the patient is doing fine. So
keep it confidential, but sometimes it's also possible in Poland.
Yeah. So maybe let's ask our other colleagues. What do you think about combining the OPN with other cutting or cracking or rotablation or IVL? Do you have any experience how about Professor Souteyrand in France?
Yes, I think it's an additional tool, and your comments about combination of all these tools is very important. I have 2 additional comments. The first is for all the patients is to in the two cases it was very interesting to see how to manage their restenosis. But we can see in these presentations that the preparation of the lesion is very important. When we can see the result of the underexpansion of the stent in the right coronary artery distally, we are in trouble to treat it because there is not a good preparation of the lesion. So it's a very important point, I think so. And another point is why finally do you add a stent after the open in the distal part of the right coronary artery? Because there was a stent just before. It was implanted just a few minutes before the OPN. So in my mind, it was not necessary to add another stent, but it could be discussed.
I didn't want to be not too much of label because even the use of IVL for unexpanded stent is off label application, and if you discuss with the company people, they have more experience. They follow every case. They say it's probably appropriate if you do applications within the stent. You are never sure if the stent structure is not broken, and this is why, at least for now, I did it. However, I know there is one case report published in the literature with just lithotripsy for underexpanded stent without additional stent implantation. We just need to gather more data, more patients, and then we will have an answer. So this was just to be on the safe side. To be honest, I am not so afraid nowadays using stents which have the stent strut thickness is around 70 microns to implant another thin strut stent, especially in a big vessel. This ride was around 4, so I believe it was. This is my answer. But however, maybe you are right that we should leave it alone without.
No, we don't know. It's important for the discussion to discuss. I think it's a good point, and I think that lithotripsy could be a good tool to treat this underexpansion too.
How about Krzystof? How about combining rotablation and OPN balloon? I've seen some cases of you. Comment on this, please.
Thanks a lot for this point. That's a very good one because I was talking 2 years ago on the Euro CTO meeting with its file, and I was telling him, I don't need any OPN balloons. I'm a heavy rotablator user. I myself perform about 80 rotablation atherectomies per year, and my colleagues do some more. So at our institution, we perform many of them, and I was quite happy. But I encounter more and more cases where I need another device like OPN balloons, and I will show you my case in a few minutes. It was actually one of the first cases of mine where I had the feeling I have to do something more than only rotablator, because rotablator alone didn't help. So combining it's extremely important point you've made, and the other things don't just address deep calcium, so you have to do something more about it, definitely.
And maybe a question for Professor Wong. What is your experience? In Asia, they use a lot of these scoring or cutting balloons. What is your experience with combining scoring, cutting balloons and OPN in native lesions or in central stenosis?
Usually, before the OPN start, we usually use angioscope or cutting balloon for very tough lesion. But in Asia, this cutting balloon and the score flags actually are much more expensive than OPN. So nowadays, we actually jump ahead, and then we just, if a very resistant lesion, we just use OPN straight away, yeah, rather than choosing one by one, yeah. And regarding combination of treatment, the case that I'm presenting is also a combination of IVL and OPN as well, yeah. But the thing is, you have to plan ahead. I mean, for IVL and OPN, whatever, you can do it in the middle of procedures, change strategy. But if you do rotablation, if you pre-dilate it, you have a lot of dissection, then rotablation may not be a good, or orbital atherectomy may not be a good idea, because it may cause us a distal embolization.
Yeah. Okay.
Well,
let's continue with Krzystof Pujdak. I'm sure he has also prepared a very nice case about a left main, and then the devil is in the detail. Very excited to hear you. The stage is yours.
Thank you very much. I will start the presentation. Thank you very much for the kind invitation to this event. I really appreciate it. It will not be a very nice case, but I hope it will still be quite educational one. So it's a patient with a complex PCI, where you will be able to see some technical failures which led to an in-stent restenosis in the later course. And I tried to show you some aspects which are important to look at during left main PCI, particularly in case of severe calcifications. So some spectators will be maybe able to prevent the in-stent restenosis in similar cases in their own practice. The patient I would like to show you is 67-year-old male presenting with stable angina in CCS3 class for many months. His risk factors are high BMI, arterial hypertension, dyslipidemia. He has quite severe chronic kidney disease, but he has no history of diabetes. His ECG is normal. Echo shows good left ventricular function with apical hypokinesia, and he has no valvular disease. Well, after performing the coronary angio or on coronary angio, we have seen occluded right coronary artery, which is severely calcified, severely diseased. The left system showed the true left main bifurcation stenosis, which was also quite calcified, as well as the quite long stenosis of the proximal portion of the LAD. Well, the patient refused the CABG procedure which was suggested to him in a heart-team discussion. So we proceeded to the PCI. First, we addressed this severely diseased right coronary artery with normal balloons, normal stents. I think we did okay. We opened it up. It's not a big vessel, but the result was satisfactory. The patient left the hospital on the third day after the PCI with the typical medication, and we planned the readmission 4 weeks later to perform left main PCI. So after some weeks, the patient was readmitted. We planned the procedure will be performed from right radial access with 7 French guiding, sheetless, with extra backup guide, 375 extra backup guide. We wanted to prepare the lesion with rotational atherectomy, 1.75 burr, and we planned a 2-stent strategy with nano crush method, which normally, or we should, allow complete lesion coverage of a bifurcation lesion without excessive metal layers. First, we checked the result of the right coronary artery. It was fine. Here we started to the rotablation from the 3.75 extra backup guiding, past the rota wire to the left circumflex artery, then put the wire into the LAD and did the same. After the rotablation, the result was not really good, which was not anticipated. We dilated the circumflex artery and proximal portion of the LAD with normal 3.0 and 3.5 non-compliant balloons, and then we put a stent, a long stent, into the LAD with a little protrusion into the left main stent. It was normal Promus Premier Select drug-eluting stent. The proximal portion of the balloon has been, of the stent, sorry, was pulled up to the stent to crush it. The first kiss has been performed. Then the next step was to put a stentus, a self-opposing drug-eluting stent, an M size, to the circumflex artery, which was deployed with 20 atmospheres. Then a kiss, the second kiss has been done in proximal optimization technique, and this was the still image of the final result of this procedure. The operator has performed OCT and has performed pullback from the LAD to the left main stem, and documented good apposition of the stent and no relevant stenosis of the CX circumflex ostium, but without going into it. Yes, as you can imagine, as you can probably expect, 6 months later, the patient came back with recurrent angina on exertion. The ECG was normal. The troponins were not elevated. So what we have done here, you cannot see this because of this small picture of the of us. You can see that the stent is definitely not expanded. You have a minimal stent area of 3.2 square millimeters, which is clearly too low. So we just took many balloons, many normal 3.0 and 3.5 balloons to post-dilate it. So it were 2.5 track, 3.5 track NC, 3.0. We inflated them up to 30 atmospheres, which unfortunately didn't result in improval of the angiographic result, but it resulted in two balloon bursts. Luckily it doesn't, luckily it didn't negatively affect the angiographic result. It didn't improve it, but that didn't destroy the artery, luckily. After this disappointing events, we took another one. The result is still not satisfactory. Then we remembered, or we came to mind that we have some new devices on our shelf, which were waiting for proper patient, that were OPN and C balloons. And then they turned out to be game changers in this situation. First, we dilated the lesion with 3.015 OPN and C balloon. Then we upsized it to 3.5 balloon and reached nice expansion and full inflation at about 40 and 45 atmospheres. And after dilating the post-dilating DLAD ostium and another final kiss and another post-dilation, we performed some OCT measurements. This time we took or we made two pullbacks from LAD to left main and from circumflex RGD to left main, and we reached satisfactory results and quite good minimum stent areas. Why is it so important? I wanted to remind you of a nice but old trial from Kang. In this study, the under expansion was defined as post-stenting MSA, or minimum stent area, of under 5 millimeters square millimeters at the circumflex ostium, under 6 square millimeters at the LAD ostium, and at under 8 millimeters at the left main artery. There were very high risk stenosis rate, about 50% in patients where the patients have been treated with 2 stents and had under expansion at least one of 4 of these segments. And angiographic ESR was very, very frequent at this patient, and conversely, angiographic restenosis was seen only in 5% or so of patients who haven't had this kind of under expansion. So very important thing to think about. Remarkably, very important thing again, the circumflex ostium was the most common site for under expansion, and thus restenosis rate. This is what we encounter in this case. So my conclusions for this quite, I think rather easy case, but quite educational, I hope. Perform intravascular imaging in all left main lesions, ideally to plan the procedure, to stent, and then to check the immediate result. And not only left main to LAD and forget the circumflex, but perform 2 checks. In heavy calcified or a heavy calcium burden, good lesion preparation is essential, but sometimes not sufficient. For example, here I thought rotablation atherectomy would be okay, but it's turned out not to be sufficient because the deep calcium of this vessel hasn't been addressed by the 1.75 millimeter burr. You have to think about your stent choice. Try to choose stents with enough radial strain. Here would be a nice discussion point: is nanocrash technique proper technique for this kind of lesions? Maybe the double kiss crush technique would be maybe better, because the big double layer or bigger double layer, which provide us probably with a little bit more radial strength at the work bifurcation and at the ostial lesions. And the other or the last conclusion will be my advice to check the result after stenting. If the MSI is not sufficient, post-dilate with ultra-high pressure. And then many people who are concerned about the use of these devices, they think the risk of perforation is very high. It is not, because not the pressure makes the perforation. The too big balloon diameter is the reason for the problems, and not the high pressure. So it definitely makes sense to have this device on your shelves and use it maybe not so late as we have done in this case. Just think about them first or second, but not at the 10th or 11th place. Thank you very much for your attention.
Thank you very much for this very nice case, and I think we learn from complications early or late, and it's important to share this case because this is a case we see in every cath lab. My comments, and then I would like to have the opinion of Professor Wong, but my first comment is, I think if you ask, I'm probably one of the most common OPN users in the world. If you ask me percentage OPN use in pre-dilatation or post-dilatation, I use the OPN balloon in 80% of the cases for pre-dilatation and in only 20% of the cases for post-dilatation. Because once you have cracked the lesion, as Professor Wong mentioned earlier, then you can use either a normal non-compliant balloon to really post-dilate nicely after you put the stent in. But you have to crack the lesion before you put the stent in. Because if you put the stent in and then the stent does not expand, then you are in a trap. And you cannot come out of this trap easily, because then you have to go automatically to very high pressure. Usually then you oversize your balloon and you perforate. And if you ask me, the last 20 perforations, did they happen in my lab during pre-dilatation or post-dilatation? 19 out of 20 happened in post-dilatation. So I think it's very important, lesion preparation, lesion preparation, lesion preparation. We have to teach also our younger colleagues, because if you see our stents nowadays, the main argument for stents from other colleagues is how easy is to deliver this stent. If a stent is easy to deliver, then you don't prepare your lesions very well. And I think this is very important to address, and I would like to hear the opinion of Professor Wong. Do you think I'm completely wrong, or you agree with me?
I totally agree with you that once you put in the stent, which is in a lesion which is not well dilated, you are in quite a big trouble. Usually, like you said, my perforation usually occurs post-dilatation rather than pre-dilatation. I totally agree with you here.
Great. So who does not agree with me from the panel? Jacek, what do you think?
No, you are absolutely right. Post-dilatation is the main, especially if you oversized balloon, which is what was said. But I thank you very much for this case, because we still struggle with ostium of the CERG when we do left main stentings. This is a common problem, and especially if you do not use. Some people say, why is it so often that the restenosis in left main, distal left main, is in the ostium of the CERG? Maybe this is because this is resistant lesion and usually not adequately prepared. And I have the same feeling that if people perform rotablation, they think everything is done. We just did rotablation. Oh, if you use 175 bore is a big bore, so usually it has to be okay. And your case beautifully shown us that that the rotablation is just a good start to do the good lesion preparation, which should contain also good balloon pre-dilatation.
Yeah, and maybe a comment regarding the technique. To be honest with you, I'm also I saw now this recently published meta-analysis with decay and crush. To be honest with you, I do not believe that the technique matters as much as matters the lesion preparation.
Yeah.
I think if you prepare the lesions well, then usually you will be fine. But if you leave it underexpanded, like in this case, correct me if I'm wrong, then no matter what technique you use, you will have restenosis.
That's correct. That's what I wanted to say as well. I think this whole discussion about many techniques, it's nice to hear and nice to talk about it, but I don't think it's really so extremely important. I think we should know our favorite techniques, and we should really do it right and prepare the lesion, and then probably it's not as big not as important as many say if it is decay crush or nano crush or TN protrusion and so on. Quite important. It is important, but I don't think it's so extremely important. What do you say?
Well, in my opinion, it's not that important, but I'm keen to hear the opinions of others. It's really if this discussion is if I'm just ignoring facts or if it's really an important thing.
The difference for me is not that one technique is better than another, but there are some differences. It's much more easy probably to do just TN protrusion than do decay crush, which you need to follow multiple steps and you have to have some experience. However, if you have the side branch which is diffusely diseased and you are afraid about the occlusion of the side branch doing the main vessel stenting, then decay crush is good because this is the technique that allows you to have access to both vessels during all the procedure without or with the low risk of occlusion of one of the branches. So I believe that this is the substantial difference. However, and decay crush is a good technique. I have experience. However, it's not very easy, to be honest. And the data we have from Asia and from very experienced operators for this particular technique. So if you have experience, very good technique. However, first you need to get some experience.
And maybe let's address a final question from the audience. I have a question. How would you approach a highly fibrotic instant restenosis without calcification? Maybe Professor Souteyrand can answer. So how would you approach an instant restenosis just fibrotic without calcification?
It's a good question. Usually, if we have only neooptimal hyperplasia without any calcification, I think that it's a good indication to active balloon for this indication. But sometimes you have to show very adequately the stent too for the expansion. It's very important. And like you can say just before, you have to prepare the lesion adequately before to do the balloon angioplasty with the active balloon, because it's not to open the lesion by the active balloon, but prepare the lesion before.
Okay, thank you very much. So now let's carry on. We go to Asia, far away from here. How late is it now there? It must be late.
It's 11 o'clock here.
Not
I
so
hope
bad.
you're not in the hospital. How are you? So share the hard case to crack with us.
Yes. Yeah. So I just going to present a case. It's titled "A Hard Case to Crack." So it's a very young patient, probably the youngest among all the cases are presented, and he had an inferior STEMI at age of 28, treated with primary PCI to the mid RCA with a bare metal stent, and 2 years later he was presented with unstable angina, and again in a mid LAD, and then treated with a very big bare metal stent. And 6 years later, when he was 36, he presented again with unstable angina. And this is the previous stent, which was implanted in the LAD. And at this time, they put in a a cipher stent 3.0 in a 5.0 stent, but it was post-dilate with the 5.0 NC balloon. I think at that time, the largest available in the lab probably is only the 3.0 DES. So the right side is a CTO. This was a previous stent near Primo 3516, and then it was treated with a DEB distally and also a cipher stent at the distal RCA. About 4 years later, when he was 40 years old, he again with the unstable angina, and then the RCA was a CTO. So LAD stent was patent, and you can see the good collaterals to the RCA, and there was a proximal lesion in the RCA as well. So this was again treated. This is an old stent. At that time, the distal part was treated with a DEB, and the mid part with a bare metal stent, and then the proximal part again with a big bare metal stent. So as you can see, there's 2 layers of stent here, which our target lesion is somewhere here. So this is another view. So it was submitted last year when he was age 80 for again with increasing exertional angina. And this is an angiogram. Show the left side. The LAD stent is patent. As you can see, the right coronary artery is occluded with very good collaterals up to the mid RCA. So this is an RCA lesion. So we intervened this RCA lesion, and it was the CTO was quite easy to cross. This is after the balloon dilatation of the RCA. So it was after a 2.0 dilatation, because it's in-stent restenosis, we use a cutting balloon 3.010 and NC balloon 3.015. It didn't dilate at the where that lesion was, and then we use a bigger balloon 3.515, and it won't dilate as well. And OPN was used because we worried that it is sort of the vessel ruptured. We undersized it to 3.015, and again the OPN balloon failed to dilate the lesions. Yeah, this is where the lesion was. So at that time, we have news that the shortwave balloon is going to be available soon. So decided to leave the mid RCA for later date for shortwave IVL. And what we did was we put a DEB distally, and then we put a proximal stent 4.018, and then this is post-stenting results. So this is the results of the first intervention, which is reasonable. As you can see, the mid part is really underdilated at this part, underexpanded. So we bring him back 2 months later when the IVL was become available, and mid RCA lesion remained unchanged, but there was a in-stent restenosis of the distal RCA where we treated with the DEB. So this time we use an IVUS. As you can see, just remember 3 areas. This is an area which there is a 360 calcification inside the stent. And then just proximal to it, there's a part which is about 180-degree calcification inside the stent. And then another part which is about 300-degree, almost 360-degree calcification here. So this is a part where it is resistant to dilatation. So we use a IVL 4.012. We measure the size pre and post. The lesion is about 4.0. So you can see this is the shock wave which was delivered. 0.80 shock was given, but as you can see on this cine picture, there was not much improvement in the IVL balloon expansion, because for IVL you're supposed to see the balloon gradually increases in size with the shock. So we use one IVL balloon, but it's still not fully dilated. So we did the IVUS after the IVL. Just remember this area, the 360-degree calcification. There is some crack in the calcium, but just small amount of crack. And then the more proximal part, it appears to be slightly more cracks here. You can see this calcium crack here at this side. So we thought we can post-dilate it with, this is the comparison between pre and post. As you can see, there's some crack here compared to pre. And then this part also, there's a crack here after the IVL. We use a 3515 NC balloon and upsize to 4015 balloon. And as you can see, this still image, there is still persistent waste at the mid RCA, even up to 24, 28 atmosphere with the NC balloon. And we decided to use an OPN again, second round. We used a 3515. As you can see at the still picture, there was still some waste here. And at the end, when we go up the pressure about 40, and the lesion actually gave way. And this is the cine with the OPN dilated, which is the OPN balloon was fully dilated. Yeah. So this is IVUS after the OPN. We will see this part. The lumen is much bigger. This is a 360 calcification, has break, and the lumen is much bigger. And then this is the 180, which have not much effect because the other side is not calcified. And the 300-degree calcification, just proximal to it, has been cracked. And then the lumen is enlarged. So with that, this is comparison. The lumen is significantly enlarged, and there was more crack seen after the OPN balloon. So with that, we put a DES. The third DES actually around that area because the lumen is pretty big. So we think that the result will be good with DES. And then proximal part, we put in a 35 18 millimeter, and all this we post dilated to 40 NC balloon. And then this is the final IVUS. It's difficult to tell which part is which, but I think you probably can recognize the 360-degree calcification is probably somewhere here. Yeah. And now it's fully expanded. And this is probably the 180-degree calcification. And then you probably can recognize a crack in the 300-degree calcification site where now it's fully expanded. And this is the IVUS comparison from post-IVL, post-OPN, and this is final stenting and post-dilatation. So this is the final picture of the right coronary artery. As you can see, the mid-RCA is fully expanded. So take-home message, in-stent restenosis initially was thought to be due to neointimal hyperplasia of smooth muscle cells, and usually benign, but we know that about 10–15% of in-stent restenosis presented with the acute coronary syndrome. Now with new coronary imaging has demonstrated neoarteriosclerosis occurs, and more commonly and earlier in DES as compared to BMS. And calcified neointimal was noted in about 5 to 10% of cases. Not uncommon, but pretty rare. The calcified ISI in this case was resistant to dilatation, even with OPN at the initial intervention. Maybe I could have used a bigger size. It may work, but I doubt it. And rotational and orbital atherectomy in this case may not work because it's being because the lumen of the calcified site was large, and the effect of atherectomy may not be beneficial. So in this case, neither shortwave nor OPN balloon worked individually in this case, but in combination, they cracked a very hard case. So these two devices may be a perfect combination for severely calcified lesion resistant to high pressure balloon dilatation. Thank you.
Thank you very much. Very impressive case. Let me ask one question. How high did you go with pressure with the 3.0 balloon in the previous case where it did not open?
48. I usually go up to to the maximum if OPN balloon did not dilate. Yeah.
Because you have, there is a special device, which I don't know if if it's available to you, which you can go even higher.
Yeah, we have the one that goes up to 40.
No. The company is hopefully listening. They need to bring you there's another pump where you can inflate to 55 to 60 atmospheres, because it's safe. If you do that with a 3.0 balloon, then nothing will happen with the vessel. Even if the balloon ruptures, it will be a contained rupture. So I think before trying with IVL, investing another, I don't know, 2,000 euro or so, one can try to go to use the max of the balloon, and if it ruptures and it does not inflate, then you say, okay, fine, we go safe and I use. But very nicely executed, fantastic result. But just from the idea, when I see that at 40 atmospheres the device struggles, and I use the other device which goes up to 55 atmospheres, and the balloon withholds this. It's not a problem. And then maybe the second comment on this, I think it's again a very impressive case of the combination. I fully agree, and maybe we should, the 4 or 5 of us here, we should combine those cases, because it's again a case of combination IVL and OPN, and I think we should write a provocative short paper with maybe 10-15 cases, because they are all well documented, and in native or ISR I think would be very nice, because we should really stimulate our colleagues not to think like this, but to really open the field and combine all the tools we have.
Yes, totally agree. Yeah.
Great. So let's see. From the panel, do you have any additional questions for this case for Professor Wong?
What I would like to say. Oh, sorry. Okay. So go on.
Maybe one short comment, because we should keep in mind that with lithotripsy, usually it happens that even with this 4-6 atmospheres after shockwave procedure, the balloon fully opens. However, not every time, and sometimes it's like in your case that this is not fully expanded. However, it worked because there were cracks confirmed by intravascular imaging. However, usually, even if the balloon fully opens, it's good to go for additional non-compliant balloon predilatation before stenting, because this is absolutely not competitive. This is not competitive, but just additive effect of both approaches.
Very good. Krzystof, you wanted to say something.
I wanted to thank for the fascinating presentation. It was really extremely nice case, because it showed the natural course of this patient for so many years. Really interesting. And I'm not sure if I did it, if I did get it right, but at the side of the restenosis, at the distal portion of the RCA, a stent of 2.225 stent was implanted, right?
Yes.
And after the whole preparation of the lesion, you implanted 3.5 stent, right? So completely different size, much bigger size. And it shows us how important it is not only to prepare the lesion, but only see the lesion with the intravascular imaging. So it's the first step to recognize how do I treat it, how should I treat it. And if I see proper size of the vessel, I can go on and prepare the lesion that the proper stent will fit in.
Yeah,
I'm totally agree with these comments, and I think that if you didn't realize the intravascular imaging, you don't implant a stent of 3.5. So I think that in this case with stent failure, it's very important to explore the vessel with intravascular imaging, and in this case it was a solution.
Absolutely. Let me see what we have questions, maybe 1 or 2 questions before we conclude. One question: can IVL be used second time if first 80 pulses fail? Would you go for another catheter with another 80 pulses?
It's it's expensive in Singapore as well. So I think if fail again with OPN, I might use another one, to try to open it out. But I think actually the device itself can shock multiple times. It's just the company actually limit the chips in order to only 80 shocks. So if somebody is pretty good with the technology or digital thing, you can actually program it and to shock multiple times. But obviously that's not recommended by the company. Yeah. So yeah, I mean, some people use 2-3 balloons in order to crack the lesion with IVLs.
And maybe
when we treat hypertension, we usually try to use multiple drugs with lower doses and not to exceed, with one or two with maximum doses. So I believe that one of the take-home messages for me from this session is that, not to go out of the borders. And sometimes it's good to combine 3 different techniques to achieve such a beautiful result, like was shown just a few minutes ago, than to try to, to go for, 80 pulses, not enough, maybe another 80. We have no data on that because it is limited by the company. So all the data we have is maximum 80. And the same, I have never used more than 50. I need to have this inflator. 38 is usually enough, and if it is not enough, maybe it's time to switch and to use other method and then go back to OPN with 40 atmospheres. This is my approach. Sometimes maybe I am not too aggressive. Then
so I think. In my experience, calcium cracks at 40 atmospheres. So at least if it's a very, if it's cerebral calcium, then you would need 40. So I think you need to have a device which you can go to 40. And very often, then from 40, if I say it's still restricted, then I go to 45, and then I give it some time. And then usually it expands a bit more. And if the balloon still looks restricted, then I go to 50. And if it's open, I wait. And then it loses some pressure, and then I fill it up again at 45. And then if it keeps the pressure and keeps the diameter, I say, okay, fine, then I'm done. But I don't know if this is right or wrong, and it's true. Today we spoke about this combination, but I think pressure is really the answer in such lesions, and we should usually go higher as long as we use the OCT or IVUS and know the vessel diameter. And that's why also my first comment for the case from Géraud, because in that case, I believe that 3.5, you did not go to very high pressure, but I think if you had gone to more pressure, like to 45 atmospheres, then you could have ruptured the vessel, because I think it was on the higher edge of the diameter. But I think it was, maybe we should conclude now. It's 5:30 in Switzerland. So thank you very much for the great cases you shared with us. I think it's one of those webinars I really liked a lot, and I learned quite a bit. I have this idea now of combining those cases. I'll write you an email, and maybe we can share those cases and put them together. I think what we learned is that OPN can be a very good option in instant restenosis. We learned that the OPN balloon can very well be combined with other devices for lesion preparation, and this is not something which we should be reluctant to do, but we should be actually, as long as we can afford it, we should do it. The most important thing is that we get good final results, good expanded stents, and I think every one of us should have in the cath lab, when we enter the door, leave no stents under expanded. It should write before they enter the cath lab, so all fellows and all colleagues see that, because the worst thing we can do to our patients is leave him with an under expanded stent.
And do not implant a stent on not adequately prepared lesion.
Very, very important. Very good cases. Thank you very much. And then I think we should conclude here. Thanks a lot. It was great.
Okay. Thank you.
Thank you.
Thank you very much.
Thank you. Bye.